we're heading straight into the heart of scientific evidence. Ever read about a new health study, maybe a treatment, and just thought, can I really trust this?
Happens all the time, right?
You're definitely not alone. So yeah, what we want to do today is give you the tools, to figure that out for yourself.
Precisely. We're going to dig into randomized controlled trials, RCTs they're called. They're often seen as, well, the gold standard in clinical research.
Standard, okay.
And our sources lay out this great guide to what's called critical appraisal, basically how you can carefully, systematically look at research and judge if it's trustworthy, if it has value, and if it's relevant.
Right.
It's really about empowering you to tell the difference between solid findings and, well, maybe shaky claims.
Okay, let's unpack this then. And this isn't just for doctors or researchers, right?
Not at all. It's for anyone who wants to be properly informed about health stuff.
Good. So we'll look at what makes an RCT solid, how to actually understand the results, and maybe most importantly, how to tell if those results could actually help you or, someone you care about. All right, first big question then. When you're looking at an RCT, how do you even start to figure out, is this study actually valid? Is it built on solid ground?
Yeah, that's the foundation. What makes a study valid? Well, it really boils down to whether the researchers used rigorous methods. Methods that minimize bias, those sneaky factors that can mess up the results, and make sure the findings are reliable.
Okay, minimizing bias. How do we check for that?
Well, one key thing to look for is whether the study followed the CONSORT guidelines.
CONSORT.
Yeah, it's like an internationally agreed upon checklist, basically. It's got 25 items, a flow diagram. It ensures the researchers report everything completely and transparently.
So it makes it easier for us to judge the quality.
Exactly. Transparency is key.
So checklist aside for a moment, what's the very first, most basic thing we should be asking?
We start right at the beginning. Was there a clearly defined research question? Sounds simple, maybe, but it's crucial. We look for the PICO elements.
PICO.
Yeah.
Right, break that down for us.
Sure, P is population. Who were the study participants? What were the rules? The inclusion and exclusion criteria for who got in is intervention. What exactly was being tested? What was the treatment?
Right.
C is comparator. What was the control group getting? A placebo, standard care, something else.
Makes sense.
And O is outcome. What was the main thing they were trying to measure? The primary endpoint.
And this is where things can get messy if it's not clear anyway. I mean, our sources mentioned some examples.
Oh, absolutely. If the criteria are fuzzy, it creates huge problems, like those early hydroxychloroquine trials during COVID-19.
Yeah.
They had mixed groups. People weren't always confirmed with PCR tests. It led to totally conflicting results, made it impossible to know what was going on.
A real mess.
Or, older corticosteroid trials in septic shock. They use vague terms like severe sepsis. How can you compare studies if they aren't even defining the condition the same way?
You can't. It makes it really hard to apply the findings.
Exactly. So clear PICO is step one. And even before that, before they even find the first patient, you ask, was the study registered in advance?
Registered, like publicly?
Yes, in a public database, like clinicaltrials.gov. This means they declare their plan, their question, their methods, their outcomes before they start.
So they can't just change their main outcome later if the results don't look good for what they originally planned.
Precisely. It prevents selective reporting, ensures transparency, and stops people wasting time and money doing the same study over again. It's a really important safeguard.
Okay, so clear question, registered up front. What's next? The big one, I guess. Randomization.
Where are the groups randomized? Yes, this is probably the most iconic part of an RCT. It's the cornerstone.
Why is it so fundamental?
Randomization means assigning people to the treatment or control group purely by chance. Not by choice, not by convenience.
Okay.
The goals are, 1, prevent selection bias, where researchers might subconsciously put certain types of patients in one group versus another, and 2, to balance the groups.
Balance them how?
So that known factors like age or severity of illness, and crucially, unknown factors that could influence the outcome, are spread roughly evenly between the groups.
The unknown factors too, that's key.
It is. That's why RCTs beat observational studies, which often suffer from confounding by indication.
Confounding by indication. Explain that a bit more.
Sure. It means the reason someone got a treatment in the real world might be linked to their outcome. Our sources had a great example with fluids.
Right, the septic shock one.
Exactly. The fluids and septic shock example. Observational studies first suggested giving lots of IV fluids was harmful, maybe even caused death.
Yeah, that sounds bad.
But the catch was the sickest patients were the ones getting the most fluids. So Was it the fluids, or was it because they were just much sicker to begin with?
Ah, the confounding.
Right. Then proper RCTs came along, like Classic or Clover's. They randomized similar patients to either get more fluids or less fluids. And guess what?
Your difference.
Pretty much. Mortality was similar. The apparent harm from the observational studies just, well, vanished when you remove that confounding by indication through randomization.
Wow. Okay, that really shows the power of randomization. So how do we know if the randomization itself was done properly?
Good question. You look at the details. How was the random sequence generated? A computer doing it is good. Just alternating patients. That's bad. Predictable.
Okay.
You also look for things like block randomization. That helps keep the group sizes similar as the trial goes on.
Right.
And stratified randomization. That tries to balance really important factors up front, like maybe how sick someone is or which hospital they're in, especially across different sites.
It's like dealing cards fairly, basically.
Kinda, yeah. Making sure each group, gets a balanced mix from the start.
So they're randomized, groups are hopefully balanced. What about keeping that assignment secret?
Ah, now you're talking about allocation concealment. This is crucial. It means the person enrolling the patient doesn't know and cannot find out which group the next patient will go into until that patient is irreversibly entered into the study.
Why is that separation so important?
It prevents clinicians from gaming the system, even subconsciously. If they think one treatment is better for a certain type of patient and they can guess the next assignment, well, they might steer that patient towards or away from enrollment.
And that introduces bias again. The sources had that cardiology example, right, with the envelopes.
They did, a cardiology RCT, where the envelopes holding the assignments weren't properly opaque. Clinicians were literally holding them up to the light to see what the next treatment was.
No way.
Yes. And what happened? They ended up putting more high-risk patients, the ones they thought needed it most, into the thrombolysis group, which then made the treatment look less effective than it probably was.
Because the groups weren't truly comparable anymore despite randomization.
Exactly. So allocation concealment happens before the treatment starts, and it's all about preventing that selection bias at enrollment.
Okay, concealment before. Then there's another layer of secrecy after they're in the trial.
Yes, that's blinding. This happens after randomization. It's about keeping patients, clinicians, data collectors, outcome assessors, maybe even the data analysts, unaware of who is getting which treatment.
And we hear terms like single, double, triple blinding.
Right. It just refers to how many groups are kept in the dark. Single usually means the patient, double, often patient and clinician assessor. Triple might add the data analyst.
Why go to all that?
Because knowing the treatment can influence behavior and assessment. This helps eliminate performance bias, like treating one group slightly differently. It tackles ascertainment bias, how outcomes are measured or interpreted, especially subjective ones. And it helps control the placebo effect.
Right, the placebo effect. If patients know they're getting the new drug,
They might report feeling better just because of that expectation. Or if clinicians know, they might change other treatments. We call those co-interventions.
can you give an example of how not blinding could skew things?
Sure. Think about those fluid resuscitation trials again. If a doctor knows their patient is in the restrictive fluid group, maybe they'd be quicker to give vasopressors, drugs to support blood pressure. That could change the outcome.
Okay.
Or imagine an open-label ICU trial, meaning everyone knows the treatment. If one group gets a high blood pressure target, the assessors might look harder for complications like heart attacks in that group just because they expect them.
So they might find more, making the treatment look riskier than it is.
Precisely. Blinding aims to keep the playing field level after randomization.
Okay, so we've got randomization, concealment, blinding. But even then, can the groups still end up different just by chance at the beginning?
They can, especially in smaller trials. That's why you always look at the baseline characteristics table, usually table 1 in the paper.
What are we looking for there?
You compare the groups on key factors: age, sex, how severe the disease is, other health problems, comorbidities. You're checking if there are any clinically important differences between the groups right at the start.
Clinically important. How big a difference matters.
There's no hard rule, but if one group is much older or has way more people with diabetes, for example, our sources kind of suggest maybe being wary if there's more than a 20% difference in a key comorbidity, or if average scores measuring severity look quite different. You have to judge if that difference could realistically affect the outcome.
Okay, so check table 1 carefully. Now, what if patients don't actually stick with the treatment they were assigned? Or they drop out? Doesn't that mess up the whole randomization thing?
That's a common issue. And the way good studies handle it is using intention to treat analysis, or ITT.
Intent to treat.
The principle is, once randomized, always analyzed. It means you analyze patients based on the group they were originally assigned to, no matter what treatment they actually received, or even if they received none or dropped out.
But wait, why analyze someone in the treatment group if they didn't even get the treatment?
Because dropping out or switching treatment often isn't random. Maybe people stopped the new drug because of side effects or they got sicker. If you only analyze those who completed the treatment perfectly, that's called a per-protocol analysis, you introduce bias again. ITT preserves the benefits of the original randomization and gives a more realistic estimate of the treatment's effect in the real world, warts and all.
Okay, that makes sense. It reflects reality better. I think I saw a modified ITT mentioned too.
Yeah, MITT is sometimes used. It still follows the ITT principle generally, but might allow for some pre-specified exclusions, like patients who were randomized but literally never got any study drug, or perhaps were found to not even have the disease after randomization. The key is that these exclusions are defined before the results are known.
Got it. So last checks on validity, study duration, and how many people finish.
Yes, super important. Was follow-up sufficiently long and complete? You need enough time to actually see the outcome, and you need most people to stay in the study.
What's most people? How many dropouts are too many?
If too many patients are lost to follow-up, LTFU, their missing data can bias the results. Our sources suggest being cautious if more than 5% are lost, and worrying about serious bias if it's over 10%, or definitely over 20%. You just don't know what happened to those people.
And this ties back to that specific issue you mentioned earlier, particularly relevant in some places.
Right, the LAMA issue, leaving against medical advice, which can be a major challenge in places like India, for instance. It's often the sickest patients who leave, maybe for financial or social reasons.
So if they leave and are lost to follow up.
The study might underestimate how often bad outcomes, like death, actually happened, because the people with the worst prognosis are disproportionately missing. That's attrition bias, and it can seriously undermine the study's findings. It shows how context really matters.
Absolutely critical point. Okay, one last validity check.
Were the groups treated equally, apart from the specific intervention being tested? Any other treatments, co-interventions, should ideally be applied similarly to both groups.
Because if one group gets extra care or another helpful drug.
It confounds the results. You don't know if the outcome was due to the study drug or the extra treatment.
Yeah.
The classic example is that old vitamin E trial in premature babies from 1948.
What happened there?
It looked like vitamin E prevented an eye condition. But it turned out the treatment group babies were frequently taken out of their 100% oxygen environment to get the vitamin E doses. The control group wasn't.
Ah, so it wasn't the vitamin.
It was likely the difference in oxygen exposure, a hidden co-intervention. Same thing can happen today if, say, in a trial like OPTPRESS or RTSNet, one group ends up getting slightly different sedation or ventilation strategies. That could skew the main results.
Okay, wow, that's a lot to check just for validity, but super important. So let's say we've done that and we think, okay, this study looks reasonably valid. Now we look at the results. How big was the effect? Could it be just chance? This is where the numbers come in, right?
Exactly. Now we get into the results section. And yeah, there are different ways studies report how big the treatment effect was. Each tells a slightly different story.
Okay, walk us through the main ones.
Well, you often see relative risk,
Mm-hmm.
RR. That compares the risk of something bad happening, like death, in the treatment group versus the control group.
So like an RR of 0.7 means?
It means the risk in the treatment group is 70% of the risk in the control group, or a 30% relative reduction.
Okay. Then there's absolute risk.
Absolute risk reduction.
They are.
This is the simple difference in the event rates between the groups.
Mm-hmm.
So if 15% died in the control group and 10% died in the treatment group, the ARR is 5%.
5 percentage points difference. That sounds more direct.
It often is. And then there's relative risk reduction, RR, which is related to RR. It expresses that absolute difference, the ARR, as a percentage of the control group's risk.
How is that calculated?
In our example, the ARR was 5%. The control risk was 15%. So the RRR is 5%, 15%, which is about 33%.
Yeah.
So same data, but a 33% relative risk reduction can sound more impressive than a 5% absolute risk reduction.
Ah, okay. So RR can sometimes exaggerate the perceived benefit, especially if the baseline risk is low.
That's the potential pitfall. A 50% RRR sounds huge, but if the risk only went from 2 in 1,000 to 1 in 1,000, the absolute difference is tiny. You need both absolute and relative measures to get the full picture.
Right. Which brings us to that really practical one. Number. Needed to treat, or NNT?
Yes, I think NNT is often the most intuitive. It tells you how many patients you'd need to treat with the new therapy compared to the control
Yeah.
for a specific period to prevent just one additional bad outcome.
How do you get that?
It's simply the inverse of the ARR. So the ARR is 5%, or 0.05. The NNT is 1 divided by 0.05, which equals 20.
So you need to treat 20 people with the new treatment to prevent one extra death in that example.
Exactly. It gives you a sense of the effort involved for the benefit. And importantly, you need to weigh that NNT against any potential harms the NNH, or number needed to harm.
NNT and NNH. Okay, practical measures. But how do we know any of these results aren't just random chance, a statistical fluke?
Right, that's where statistical significance comes in. You'll see p-values. The common threshold is p 0.05.
Meaning less than a 5% probability the result happened by chance if there was truly no difference between treatments.
Correct. But p-values have limitations. They don't tell you the size of the effect or the precision of the estimate. That's why confidence intervals, CIs, are often more informative.
Confidence intervals, usually 95% CIs.
Typically, yes. A 95% CI gives you a range of values within which we are 95% confident the true effect size lies.
How does that help us judge significance?
You look at whether the CI includes the value that means no effect. For relative risk, RR, or odds ratios, or that value is 1.0. For absolute differences like ARR, it's 0.
So give us an example with RR again.
Okay, if a study finds an RR of 0.80, suggesting a 20% risk reduction, but the 95% CI is, say, 0.60 to 1.05.
It crosses 1.0.
Right. Since the range includes 1.0, no difference, we can't be 95% confident the true effect is different from no effect. So the result is not statistically significant at the 0.05 level.
But if the RR was 0.67 and the 95% CI was 0.45 to 0.98?
Now, the entire range is below 1.0. It doesn't cross the line of no difference. So this result is statistically significant. We're 95% confident the true RR is somewhere between 0.45 and 0.98, meaning a reduction in risk.
And the width of that interval tells us something too, right? About precision.
Absolutely. A narrow CI, like maybe 0.85 to 0.95, means the estimate is quite precise, usually happens with larger studies, less random error. A wide CI, like 0.20 to 1.10 error, means the estimate is very imprecise, very uncertain. There's a lot of statistical noise.
So we need to look beyond just P 0.05. We need to see if the CI excludes no effect, how wide the CI is, and if the estimated effect size, like the ARR or NNT, is actually large enough to be clinically important, not just statistically significant.
You've got it. Statistical significance doesn't automatically equal clinical importance. And an imprecise result, even if technically significant, might not be something you want to base decisions on.
Okay, this is making sense. We've checked validity, we've looked at the results, size, significance, precision. Now, the final hurdle, maybe the most important one for the listener, can these results actually help me or my patient? This is about applying it, right? External validity.
Exactly. The rubber meets the road here. Just because a study was well done and showed a significant result doesn't automatically mean it applies to your specific situation.
What questions should we be asking ourselves at this stage?
First, is my patient, or am I, fundamentally different from the patients included in the study? Think about age, severity of illness, other health conditions, maybe even genetics or background. If your situation is very different from the study population, the results might not apply.
Okay, patient similarity. What else?
Then, practicalities. Is the treatment actually feasible in my setting? Do we have the resources, the expertise, the monitoring capability? Is it affordable? What are the alternatives?
Right, the real-world constraints.
And crucially, will the potential benefits, as shown in the study, outweigh the potential harms, costs, and inconvenience for this specific individual? That risk-benefit calculation can be very personal.
And involving the patient's own views.
Absolutely essential. What does the patient actually want? What are their values and preferences regarding the potential outcomes and side effects? Shared decision-making is key.
You mentioned earlier how context, like in India, can really affect this applicability, the external validity.
Yes, those factors are critical. Differences in the types of diseases people get, like more tropical infections. Differences in resources, nurse staffing, available tests, health system issues, cost, that LAMA phenomenon we discussed, end-of-life care policies. All of these can impact whether a result from, say, a high-income country trial translates effectively.
Can you give us another concrete example of this translation issue? Maybe one where it did apply and one where it might not.
Sure, let's take the nice sugar trial again. Big ICU trial showed tight glucose control increased mortality. It was done in well-resourced ICUs in places like Australia, Canada, the US.
Right.
You might ask, does that apply to a less resourced ICU, maybe in India or elsewhere where frequent blood sugar checks are harder? Well, arguably, yes, it applies even more strongly. If tight control was harmful, even with good resources, it's likely to be at least as harmful, maybe more so, when monitoring is difficult. So the external validity was pretty high there.
Okay, that makes sense. What about an example where it might not translate well?
Consider the EOBO trial. It looked at ECMO, a very complex life support system for severe respiratory failure, ARDS. It showed a trend towards benefit, but wasn't clearly statistically significant. Importantly, this trial was done in centers with huge expertise in ECMO.
Highly specialized places.
Exactly. So could a smaller hospital with much less ECMO experience expect even that level of benefit? Probably not. The risks of complications might be higher, the potential benefit smaller. So the external validity of the EOAA results to a low-volume center is questionable. The local context, expertise, and resources is paramount.
That's a really powerful point. Even the best science, the most valid RCT, needs that final filter of individual circumstances, local realities, and patient preferences.
Wow, what a journey. We've really dug deep into how to critically appraise an RCT, from checking its basic validity, the foundation, through making sense of the stats, the significance, the NNTs, all the way to figuring out if it actually applies to you. Hopefully everyone listening now feels they have a better toolkit. Yeah, the goal is to be able to ask those smarter questions, right? To look at a study and think about the PASIO, the randomization, the blinding, the ITT analysis, the confidence intervals. It's about understanding how we know what we think we know.
It really empowers you to be a more discerning consumer of health information.
Definitely. Knowledge is great, but applied knowledge, understanding the strengths and weaknesses, that's where the value is. Assessing if findings are truly trustworthy and relevant to your world.
So let's leave our listeners with a final thought, something to chew on. The next time you see that big headline, "New drug cures X," or "Study proves Y," don't just take it at face value. Think back to our conversation. What's the one thing, the first element of critical appraisal you'll look for to start deciding if that study is truly meaningful for you?
That's a great challenge. What's your first filter?
Thanks so much for joining us on the